Good evening, friends. Good evening, friends. INI-CET November Psychiatry subject. First question, match of the following: kleptomania, pyromania, dipsomania, nymphomania. Yes, impulse control disorder. You all are aware about impulse control disorder. Yes, patient is unable to control impulse. Yes, suppose I am a person having kleptomania. I go to a shop. Yes, I have intense desire to pick up a comb. Yes, yes, impulse will build up anxiety. After some time, I will not be able to control myself, and I will pick up the comb. And will feel relaxed. After some time, will feel guilty. So this is crescendo, decrescendo type of anxiety. So this is impulse control disorder, kleptomania. Pick up the things, steal the things. Yes, a persistent neurotic impulse to steal, especially without economic motive. Without means, what does mean? Yes, if a person says that I want to make the diagnosis of kleptomania and I go to a jewelry shop and pick up the jewelry, that is not kleptomania. Yes, the item which you steal, that is of very little value. No economic factor should be there. One thing. Good evening, friends. Yes, so kleptomania, pyromania, to set fire. Okay, dipsomania. Yes, dipsomania usually make mnemonic. Yes, whenever you take alcohol, you must have done this. You dip your finger and do this. Dipsomania. Yes, uncontrolled craving for alcoholic liquors. Okay, nymphomania. Yes, uncontrollable sexual desire. So you can easily mark the answer. Kleptomania, A is 2, pyromania, B is 3, C dipsomania is 4. Yes, D is 1. Answer is A. Okay, so impulse control disorder, every time this question is being asked, the reason is that in impulse control disorder, recently trichotillomania and pathological gambling has been reclassified. Trichotillomania, previously it was impulse control disorder. Recently it is classified under obsessive compulsive and related disorder in ICD-11. Okay, this pathological gambling is classified under substance use disorder. This question has been asked previously in INI-CET. So they are focusing a particular topic every time on which classificatory changes are there. So you can expect a few more questions in your NEET. Okay, in ICD-11, one more diagnosis, compulsive sexual behavior disorder. You will remember this. Okay, this is also impulse control disorder. Clear? So many times you will find question like this. Theoretical question you may find: a young woman has history of more than 10 arrests for stealing small items. She belongs to a wealthy family and her parents do not understand her behavior. At home she has a numerous salt and pepper shaker, ashtray, none of which she needs. Okay, so this is kleptomania. To put things on fire, pyromania. So this question is clear. You can put your inputs also. Yes, this is question. Yes, complete question. If you have any input, you can tell me. 14-year-old girl, mother dies. After that she got blind suddenly blind. She was not bothered about it. That is, affect is not matching with the loss. She is blind. Blindness is a very big loss. If a blind person comes to OPD or emergency, will say, Doctor, please save me. My eyes are gone. I can't visualize. But this girl would say, Doctor, I can't see. This should not be the emotions. This should not be the affect. That is called la bella indifference. Means if emotions not matching with the loss, they are called as labella indifference. This is seen in dissociative disorder or conversion disorder. Yes, according to ICD-11, and conversion disorder old name was hysteria. Hysteria, wandering uterus. Yes, you can easily remember if hysteria, hysterosalpingography, hystero word is related to females, so it is more common in females than males. So it may be adult or children, it is more common in females. This is dissociative or conversion disorder. Better to say it is conversion disorder. According to ICD, it is part of dissociative disorder, but according to DSM-5, conversion disorder is part of somatic symptom and related somatoform disorder or somatic symptom and related disorder. Somatoform disorder or somatic symptom and related disorder. Okay. Yes, first part I am discussing. Okay. Yes, second part I will release soon. Okay. Yes. Gambling. Yes, pathological gambling. Patient will do gambling until everything is lost. Okay, pathological gambling. Previously it was impulse control disorder, ICD-10, but according to DSM-5 and ICD-11, this is substance abuse disorder or substance related disorder. Okay. So third question, this question was asked. Okay, receptor wise action. Yes. 53-year male who is chronic alcoholic tried to stop using alcohol after several requests by his family member. Okay, this question, I don't know what was the exact question. Okay, you must be knowing, but I usually tell whenever you find clouding of consciousness and acute few days history clouding of consciousness without second thought, you will mark the answer delirium. So if hallucination is there, delusion is there, aggressive behavior is there, pulling cannula is there, yes, fluctuating course is there, I don't care about these things. I care only one thing, that if clouding of consciousness or acute confusional state, clouding of consciousness, acute confusional state is given, yes, without second thought, this is delirium. And in delirium, if there is history of alcohol, delirium tremens. History of alcohol, delirium tremens, and in this tremors, sweating, all these symptoms would be there. So simply clouding of consciousness, delirium, history of alcohol is there, shaking, tremors are there, delirium tremens. And in delirium tremens, best treatment is IV lorazepam plus IV injection thiamine. Yes, injection thiamine. So this is delirium tremens. But in question, as a student told that lorazepam was not given, diazepam would be the answer. Best is IV thiamine plus IV lorazepam. Okay, clear? Yes. So this is, so again I repeat, this is every year this question is being asked, every exam, wherever you find clouding of consciousness, confusional state, delirium plus tremors, delirium tremens, history of alcohol withdrawal would be there. Okay, and delirium, the treatment is low dose antipsychotic. Delirium tremens, there would be IV lorazepam plus injection thiamine. Okay. Now next question, a patient with chronic alcohol use, around 1 bottle. Yes, this is as a student told that, yes, you can put input. Yes, so they, in fact this question is repeat question, previously asked question. Yes, if 3 times this question has been asked, not this time, in long time back question was asked, there is a intern posted at PSC, and now a patient came, liver function test availability was not there, and patient was chronic alcoholic and he wanted to do detoxification, which benzodiazepine he should prefer. So if liver function test is not available, machine is not working, or emergency machine is not working, you will prefer to start lorazepam or oxazepam. Okay, in this both option, lorazepam and oxazepam, if both are given, definitely it is difficult to differentiate. They will not give both, either lorazepam or oxazepam. Okay, if lorazepam is given, answer would be lorazepam. If oxazepam is given, answer is oxazepam. Okay, so lorazepam and oxazepam both are short acting because they are metabolized by conjugation. Okay, so if liver function test is not normal, even then you can utilize. Okay, therapeutic dose of lithium in acute mania. Yes, that is therapeutic dose 0.8 to 1.2 milliequivalent. Many times questions are asked. Yes, prophylactic 0.4 to 0.8. Now, in synopsis itself, it is given at same page 0.8 to 1.5 milliequivalent per liter. So don't get confused. Yes, more than 1.5, it produced toxicity. So many questions recently asked that if you start lithium today, after how many days you will check serum lithium level? After 5 to 7 days, because after 5 days lithium will acquire plasma steady state concentration, because any drug acquire plasma steady state concentration after 4 to 5 half-lives, and the half-life of lithium is 1.3 days. Okay, question was asked, lithium, yes, if you want to take sample to estimate lithium, when you will take sample? Usually we give lithium TDS, morning, evening, night, okay, or BD, morning, night. Then you will take the sample after 12 hours of last dose. Means suppose patient came to me today, I will ask the patient, okay, 5 days, after 5 days you will come, you will not take the morning dose, means after 12 hours of last dose, and after how many days? 5 days. If you have done internship, you will be aware about this, that whenever we start lithium, we check lithium level after 5 days, 12 hours of last dose. Okay, and lithium is having, yes, narrow therapeutic index, one where, yes, in this question answer is B. Few students told that it was 1.5. okay, now lithium is having antisuicidal property. Question, lithium side effect and toxicity, very important. If coarse tremors, this is normal side effect. If fine tremors, it is normal side effect. If it is coarse tremors, yes, coarse tremors, then it is toxicity. Suppose a patient came to me, I am sitting in OPD and patient is on lithium, is having no tremors. You ask the patient to stretch hand. And hands are shaking. This is fine tremors. You will give beta blocker. In coarse tremor, yes, patient came to you having, coarse tremor, patient is having tremor in the hand, then it is coarse tremor. Yes, you can visualize, you will check immediately reflexes, there would be hyperreflexia. Patient may go into coma, death. So immediately send the patient or send the sample for serum lithium level. So remember this, fine tremors, coarse tremors. In fact, side effect is nausea, and toxicity, usually there is vomiting. You can't differentiate on the basis of nausea and vomiting, but side effect is usually nausea and toxicity is usually vomiting. Okay, in clinical scenario you will find like this. Okay, one important question, if question is asked acute mania. Best treatment is, yes, what is the drug of choice? Atypical antipsychotic. If one to choose out of atypical, olanzapine. It is better than, yes, olanzapine, yes, better than lithium or valproate when used monotherapy. This is latest edition of Morsley. If monotherapy, that is lithium or that is olanzapine. Now, doubt, still confusing in alcohol withdrawal emergency. Yes, Patel. Alcohol withdrawal emergency management of patient with alcohol withdrawal symptom. Could you please briefly describe it? Okay, in alcohol withdrawal, yes, suppose a patient came to me having alcohol withdrawal symptoms, yes, or taking alcohol, I will detoxify the patient. Detoxify means whenever patient stop taking alcohol, alcohol is CNS suppressant. When you stop taking alcohol, CNS becomes hyperactive. Okay, so that's why to the exact mechanism of benzodiazepine is like alcohol. So we can replace alcohol by benzodiazepine, and in detoxification we use benzodiazepine. Okay, suppose any patient came to me having alcohol, he has not taken alcohol for 1 day, 2 days, yes, and if he is having no severe symptoms, I will start this in this oral form. But if patient is having seizures, yes, generalized tonic-clonic seizure, usually this appear at second day, usually, but it's not a diagnostic. If seizure are there, then you will give IV diazepam, plus thiamine. Yes, you all know that every time, whenever there is alcohol-related any disorder, you will use thiamine. I usually say whenever you take alcohol, don't take alcohol, but whenever you take alcohol, keep always thiamine with you. After taking alcohol in the morning, we usually take Nimbu Pani. No benefit. You should use thiamine, because in the treatment of all, yes, all disorders related to alcohol, Wernicke's encephalopathy, yes, IV thiamine. Korsakoff psychosis, oral thiamine. Delirium tremens, IV lorazepam plus IV thiamine. Yes, alcohol withdrawal seizures, that is IV diazepam plus IV thiamine. So in this, got the point? Emergency patient management. What is emergency? Emergency is delirium tremens. Emergency is seizures. If after stopping alcohol, if a patient come clouding of consciousness, just like in this question, clouding of consciousness, delirium tremens, death rate is very high. Generalized tonic-clonic seizure, alcohol withdrawal seizure, that is emergency, because this in alcohol withdrawal, these seizures come in cluster. In a short time, multiple seizures would be there. Okay, and we prefer diazepam in seizure because diazepam is long acting, lorazepam is short acting. That's why we want to give long acting in seizure. Diazepam is better. Okay, got the point? Second doubt. So alcohol question includes that the person was in de-addiction period and the history was of consumption of 2 days back with symptom of tremens. Yes, 2 days, 3 days, 4 days. Yes, after alcohol withdrawal, I usually say in any question you find clouding of consciousness, altered sensorium, disorientation, yes, without second thought, delirium plus tremors, autonomic instability, history of alcohol, delirium tremens. Got the point? Okay, so we have covered first session question. I will come, yes, you have given few hints of second session. I will make the questions all in options and will come back to you soon. So till then, continue your study. Best of luck. Thank you.